Folks, we are going to reconvene because I am greedy for information, and I am not going to, so I'm going to try to wring as much knowledge as we can out of our remaining 3 speakers. As you see, we're pretty good at wringing a lot of knowledge out of all of our speakers. Okay, so well, I think most of our committee members, here comes Ron, and then we'll start.
And I just put press that button for red. So
yeah, if it says, if it's red, you're good.
Okay.
So once again, let me welcome all the people who are watching and or listening online. I'm so grateful that we have the opportunity to share this session with all of you. And if you have comments after the fact, please feel free to share them with us, because as you hear, we read a lot. Okay, Dr. Jason.
Thank you. These slides are available to your committee as well as anybody else who might like them. I've been asked to answer several questions. The first one is, what are the natural history of ME/CFS? What are the limits of such studies presently? At this point, very few studies are in this area, particularly with the best methodology, which involves prospective, community-based samples. One such study was done by our team in Chicago, where we examined the course of ME/CFS over a 10-year period of time with the prospective, random, community-based, multi-ethnic sample. There was relative stability over time on critical measures of disability, fatigue, support, optimism, and coping over time. The rate of ME/CFS remained approximately the same over this 10-year period of time. Post-exertional malaise best differentiated the ME/CFS group from other groups, including control, idiopathic chronic fatigue, or medical psychiatric reasons for fatigue. This finding reaffirms the importance of this being a cardinal and critical symptom for ME/CFS. Also, for unrefreshing sleep and impaired memory and concentration, 100% of the ME/CFS group had these symptoms. Similar to post-exertional malaise, these results support the idea that unrefreshing sleep and impaired memory and concentration are core symptoms of ME/CFS, as was also suggested on the prior panel. Next question I was asked, do certain symptoms in ME/CFS appear to cluster together? I restated this. Are data available on how symptoms covary and how? In order to accurately diagnose an illness or disease, it's important to have a reliable set of criteria for clinicians. Otherwise, it's possible that disagreements about diagnostic decisions may arise because of diagnostic unreliability. Criterion variance, classification of patient symptoms into diagnostic categories. Criterion variance constitutes the largest source of diagnostic unreliability. This occurs when an operationally explicit set of criteria is not being utilized in the process of diagnosing an illness. Therefore, a case definition needs to specify the core cardinal features of any illness, such as ME/CFS. However, in recent systematic reviews, over 20 case definitions have been identified. The problem is that different case definitions specify different symptoms. Factor analysis can be used to determine which symptoms covary. Factor analysis identifies latent dimensions. A number of factor analytic studies, as indicated in the slide above, have resulted in 3 to 4 symptom factors. One such study our group did by Brown and myself, and we identified 3 factors. The reason I mention this particular study is that it was a study that had 2 different data sets. We had an exploratory and a confirmatory factor analysis done that confirmed these factors. In the interpretation of this study, and it's, again, just one example of many that could have been talked about, 2 of the emergent factors were neurological cognitive dysfunction and post-exertional malaise. This fits well with previous literature indicating that these are 2 of the cardinal symptom clusters of ME/CFS, again, very comparable to what was said in the prior panel. One factor also involved neuroendocrine, autonomic, and immune dysfunction. It's more difficult to interpret this factor as it incorporates many symptom clusters. This suggests that there may be core, well-identified symptom clusters, such as cognitive impairment and post-exertional malaise, but also there might be many other symptoms that are experienced differently by patients. Next question is, are there short screen tools that have been validated for ME/CFS? Regardless of which case definition is used, it's critical to assess symptoms in a standardized ways to reduce reliability issues. This could be done by, for example, the Wagner CFS symptom inventory. By using a consistent set of items on a questionnaire or measure, as well as cutoff points for defining whether a threshold has been met for symptom criteria, clinicians will be able to examine the same illness constructs among all of their participants or patients. It's not easy to determine whether a patient meets an ME/CFS case definition. Some investigators, for example, have found that over 90% of those with CFS Fukuda criteria also meet ME/CFS Canadian clinical criteria. There's another group that has found that 50% of those who meet these two criteria. So this variability suggests that different investigators might be using different scoring rules for diagnosing ME/CFS using the Canadian clinical criteria. Our group in Chicago has developed what's called the DePaul Symptom Questionnaire, the DSQ. We developed it. It's a structured approach to gathering standardized information and allows investigators to determine whether or not a patient meets the diagnostic criteria. After completing the DSQ, there's an algorithm which determines if a patient meets case definitions, including, for example, ME/CFS, the Canadian criteria, MEICC, the most recent myalgic encephalomyelitis criteria, and the Fukuda 1994 chronic fatigue syndrome criteria. The psychometric properties of DSQ are excellent in terms of good test-retest reliability, suggests the overall instrument is reliable measure for examining symptoms and illness constructs within the patient community. We've also had another test-retest sample from another country that has found similar results with this instrument, and also the Brown and Jason article indicated excellent internal consistency reliability. The DSQ is now being used in countries around the world, including Canada, Mexico, Iran, England, Norway, and France. It's being used in collection efforts with the CFS Association Biobank, the CDC multi-site trial, the Chronic Fatigue Initiative. It's also being used in efforts to document specific vision-related abnormalities among patients. A group of Iranian investigators are currently examining other properties of the instrument, and a specialty clinic in Vancouver is using this instrument with new patients. There's a need to standardize use of measures. What this does is allow for well-defined characterization of a patient's illness. Thus, clinicians may be able to better determine when examining those with ME/CFS or CFS. Ultimately, you want to identify and work with more homogeneous samples. This particular instrument is freely available. The DePaul Symptom Questionnaire is officially in the REDCap shared library, and if an institution does not subscribe to REDCap, it can be accessed through this link that we can make available. In terms of validated questionnaires and tools used for the diagnosis of ME/CFS, the question is, how do patients with ME/CFS compare to other sick controls? The SF-36 has frequently been used to make these types of comparisons. It's a measure of disability. ME/CFS is an illness as debilitating as type 2 diabetes, congestive heart failure, MS, and end-stage renal disease. And these studies go back over the last 10 years and the more recent ones as well. What types of sick controls have been used in the past in your or others' work? What work is in progress? One longitudinal study of youth after developing mono, those who recovered and those who did not were followed up at 6, 12, and 24 months. In this study, we found that days spent in bed since mono, along with autonomic symptoms, were associated with post-infectious ME/CFS at 6 months. I think that what we really need to include in these studies and others is both physically active and inactive healthy controls. Such studies could help us explore whether deconditioning is associated with ME/CFS and the major outcome measures. I might add that studies of exercise deconditioning using careful case control studies have not been able to explain ME/CFS on the basis of exercise deconditioning. Can we distinguish between ME/CFS and major depressive disorder? In one study using discriminative function analysis, 100% of patients were classified correctly as having ME/CFS or depressive disorder. The primary predictors were percent of time fatigue was reported, post-exertional malaise, unrefreshing sleep, confusion, disorientation, shortness of breath, and severity of self-reproach. Might add that individuals with ME/CFS do not generally experience self-reproach. Those with major depressive disorder do. We've also tried comparing ME/CFS to MS and lupus. An early version of our scale, we tried to differentiate patients with ME/CFS and those that are healthy. It was very successful in doing that. Much more difficult to distinguish ME/CFS from other autoimmune diseases, especially lupus. We're now in the process of recruiting larger samples of controls with ME, MS, and lupus to see how they differ from those with ME/CFS using DSQ. In general, we recommend a two-stage research design. The stage 1 is a screening instrument with good sensitivity. Stage 2 is a medical assessment of ME/CFS positives from stage 1 to deal with the specificity problem. Extreme care needs to be done with low prevalence illnesses in this diagnostic exercise. Based on epidemiological evidence of 0.42% of the sample in the U.S. having this illness, if you had 100,000 individuals, you'd get approximately 420 cases of ME/CFS. According to Bayes' theorem, if a case definition had a 95% rate of sensitivity and 95% specificity, generally you do well identifying those people with the illness, 399 of 420. The problem is you'd also identify close to 5,000 people who did not have ME/CFS but were identified as having it. This happens when illnesses have a low prevalence, and that's exactly the situation that we have with this illness, and that's why we have to be so careful with the case definitions. Most importantly, we need to define what counts as a symptom. Many questionnaires have measured severity but not frequency. Both need to be considered. Some symptoms, for example, are very severe, but if they occur rarely, they're less likely to be considered a problem. Also, many investigators consider mild severity as a cutoff point. This decision can lead to including too many individuals into the case definition. Let's try to get a little bit more specific about this particular issue. In the DePaul Symptom Questionnaire, we measure frequency and severity using this 0 to 4 scale. As you can see, for frequency, it goes from none of the time to a little of the time 1, about half the time 2, most of the time 3, and all of the time 4. So the higher the number, the more frequent. In terms of severity, a 0 would be symptom not present, 1 would be mild, 2 would be moderate, 3 would be severe, 4 would be very severe. Let's just take this particular rule that was set up. If we said that an individual to be counted as having a symptom had to have 1 or higher for frequency and 1 or higher for severity, let's take a look at what the data look like from a well-described sample. This is a sample of individuals who basically were tested. The darker background is CFS, the tan background is controls. And as you can see, for these particular symptoms, which are basically the Fukuda symptoms, you see that basically the individuals with ME/CFS are pretty high on just about all the domains of 1-1. However, the problem you'll notice is that the controls in the tan are also very high. This is the percentage individuals that meet criteria of a 1-1. So in terms of a mild symptom, many people who are healthy controls are going to score at 1-1 frequency. That's a major problem if you have lots of people meet these symptoms. And this shouldn't be kind of unexpected because the symptoms that we're talking about in the Fukuda criteria are actually relatively common in the general population, as this suggests. Now, the individuals with ME/CFS have a higher percentage of these particular symptoms, but you can see controls do also. Almost 34% of controls would meet the Fukuda symptom criteria when asked to basically have a 1 frequency, 1 severity cutoff point. Now let's change the decision rule just a little bit. And what you see up here is a 2-2. So in other words, if you asked every individual to meet the 2-2 criteria to decide whether to count them as a symptom, you'd have to have the individual about half the time to all the time, moderate to very severe, to basically meet criteria. No, go to that one. Now hit it one more time. Take a look what happens when you switch to a 2-2. We'll just go back again. Take a look at, this is 1-1, okay? Look what happens when it goes to 2-2. You can see the differentiation between the patients and the controls gets very severe. So in other words, these are the individuals who are controls who basically meet 2-2. It's a very small percentage of them. But the patients still have a very high percentage. And you can also see that the primary ones tend to be the post-exertional malaise, sleep, and neurocognitive issues with some pain. They tend to be a little bit less here. So again, the criteria that you select is absolutely critical. I'm just going to do that one more time because to show you the importance of this. Take a look at that. Now, the reality is there's quite a few investigators who are using 1-1 criteria to diagnose this illness. And that's a major problem because there's been no consensus in the field as to what the cutoff points need to be. If these cutoff points vary by investigator, you have what's called incredible reliability problems across different laboratories across the United States and the world.
Can I ask you? So what data set are those results from?
This is from the Biobank data set,
Okay.
the CFS Association collected.
Great, thank you.
Okay. The Canadian clinical criteria, I'm sure everybody here is familiar with. The reason I kind of put those couple of those symptoms in red is that, again, you'll see these symptoms come up again and again from the testimony from the panel members as well as from the data. These are the symptoms that tend to be the most frequent. Post-exertional malaise, sleep dysfunction, neurocognitive impairments. And they are required within the Canadian criteria. And that's one of the advantages of these particular criteria over the Fukuda criteria, which is a polythetic criteria, which you only need to have 4 out of 8. So one of the problems with the Fukuda criteria is that these cardinal symptoms from the patients' panels, from the data that we're presenting, an individual could miss these 3 particular criteria, which we think of as core ones, and still be diagnosed with Fukuda CFS without having the cardinal symptoms of this illness. That cannot occur with the Canadian criteria, which is one advantage of it. These are the symptoms based on the Canadian criteria, and I think what you can see, again, is that fatigue, sleep, and again, this is patients and controls once again, post-exertional malaise, neurocognitive, these tend to be the ones that have the highest frequency. Pain tends to be a little bit more variable, and then you have these other domains, immune, neuroendocrine, and autonomic, which again tend to be at 50% or less of patients. Another question that I was asked to give some information about is, are there any data on how patients of different ethnic, socio-demographic backgrounds present? Are there any differences in terms of presentation or course of illness? There are very few studies that have examined these questions. Most research has been on Caucasian samples. One data set that we have from an epidemiological sample looked at symptoms for individuals, for minorities and Caucasians, and as you can see, from up on the figure, individuals who are minorities, which are in the light color, tend to have higher severity ratings for Caucasians. So it does look like the old notion of this being a yuppie flu is just not the case. We also found that prevalence rates of ME/CFS were actually higher in the individuals who were non-Caucasian. We also examined fatigue across African American, Caucasian, Latino, and Asian American samples. It turns out that Latinos who were female, older, and lower SCS reported the highest severity of fatigue. And you can see up here one example of that. These are basically females. These are males. Females are in tan color. These are Latinos. And Latinos have significantly higher levels of fatigue, particularly in reference to the males. This slide also is another kind of breakdown. These who are lower socioeconomic status, higher socioeconomic status, mean fatigue scores. And as you can see, those who are older and lower SCS among these Latinos tended to have the highest levels of fatigue. So again, these are some differential rates. But as I said, there aren't a lot of studies on these types of characteristics.
Can you tell us the sample size for those?
I'd have to get back to you, but this particular sample was based on a community sample of about 17,000. In what ways are community-based patients different from those recruited from referral specialty centers? This issue has also not been well explored. Almost all studies with patients with ME/CFS have relied on referrals from physicians or health facilities. One study that from our group did compare individuals diagnosed with ME/CFS in a community-based sample to patients with ME/CFS who were recruited from tertiary care. Significantly more minorities in the community versus tertiary sample. Within the ME/CFS community sample, 45% were white, 15% black, 29% Latino, 10% other. However, in the tertiary sample, 93% were white. However, the symptom criteria were significantly higher among the tertiary as compared to the community sample. For example, memory and concentration problems, 96% in the tertiary sample, 74% in the other sample. Sore throat and tender lymph nodes. So we do see differential rates of symptoms across these samples. I was also asked to comment on my thoughts about the IOM with Go4 veterans, and I apologize, this will be a little bit technical, but just give you my 2 cents. In their review of factor analytic studies, the key question was whether the factor structure varies among compared populations. As the report stated, that question is most appropriately posited as a formal statistical test, which means the probability of observing the differences between the factor structures in the samples is estimated under the null hypothesis that the factor structures are the same in the two populations. Unfortunately, almost all the existing studies of factor structure differences have failed to test the hypothesis directly, and none have used structural equation models. Okay. In closing, some of the things that I believe need resolution for the field, one is to reduce criterion variance, one needs to decide one case definition to use. That will facilitate clinicians identifying patients with similar core symptoms, and most importantly, will reduce this problem of criterion variance. But just as important, one can't just identify a case definition, one has to also indicate how is one going to implement that case definition. So one needs to specify instruments to measure the symptoms. And one can develop with such an instrument algorithms to help determine whether a patient meets the case definition. So this can all be automated. In our DSQ, we have done that, and I would recommend that you find instruments and instruments that can do that. I also think that there's lots of questions that are raised by our current case definition. It's almost kind of like a foundation of questions that really hasn't been well studied, that also contributes to all types of reliability problems in our case definitions. These include defining onset, defining substantial reductions, defining whether lifelong fatigue exists, defining time periods for symptoms, 6 months, 1 month, 1 week today, defining cutoffs for frequency and severity of symptoms, as I've suggested. I could easily list at least 20 different issues that have not been systematically considered, and they're all critically important for a case definition. So this is one example of something that seems relatively straightforward, but is actually a very complicated issue. And I think even the panel that we had before really, I think, commented on this issue. So this really talks about, it's in one page, it gives a patient's history from 1974 to 2013. And I might add, this is a student who's doing her doctoral dissertation on trying to understand what onset is. And by putting this in a one page, one can see that the question of onset is not as simple as sudden versus kind of quick onset versus gradual onset. I mean, it's such a more complex issue for us to understand. For this particular patient, and one of the nice things about this is that you can actually see a person in one sheet. So you can imagine what it's like if you could just go into your physician and sort of show this to them, and that would really help in the communication process as well. But for the issue of onset, you know, was it when the person got mono first? Was it when the second time they got mono? Was it the third time they got mono? Each of these times, this is their level of functioning for this particular patient. And you can see they were functioning at a high level, got mono, and then started going downhill. Was this their onset? Was this their onset? Was this their onset? And this is one way of kind of seeing this person continuing to decrease in functioning over this long period of time. But again, it tells a story that's much more rich, contextual, and I think that's what we need to be able to be thinking about on these complex questions that seem so simple, but are much more difficult for us to measure adequately, particularly in a way that's reliable across different settings. Go to our last. Okay, this is my my last slide, so I'll be wrapping things up. Hopefully, I've kept things to my. Good. All right. I can then I can slow down a little bit toward my last slide. I wanted to make sure I got through it all. So I think that in the critical decisions before your committee. And I think some of this was actually hinted at by the prior panel. I think collecting and sharing data from patient groups, from clinicians, NIH, CDC, CFS and ME, using both quantitative and qualitative methods to inform an interactive and transparent process. This will help secure the participation of key stakeholders. And I might add that there's actually a history, for example, in the name. There's several people who are here who are on the name change working group that met from 2001 to 2003. And this process actually occurred where we had polls that were given to different constituent groups as we basically tried to come up with a new name. Now, I think that process we can learn something from, but it's an interactive process, it's an open process, it's a process that allows us to share data. I think one of the questions that a number of you mentioned was, well, what do patients think? Well, you don't want 3 or 4 patients to tell you what they think. You want hundreds of patients to give you their impressions, because that's the way you build a consensus towards some type of change. The second issue that I'm putting up on this slide is that I think we can learn from experiences of other diseases which have developed infrastructures to oversee refinements of case definition criteria. So let me just emphasize infrastructures, structures, mechanisms, systems that allow us to see this as an ongoing process. So what I would recommend is the development of an ongoing, flexible, adaptive system that encourages clinical trials, research, and the incorporation of new findings into case definitions. So it's not thought of as a static system, but as something that continues to get refined over time as science progresses. Thank you.